Hey, Adam, how you doing? Think you're muted.
I'm so used to the Zoom thing just defaulting to the unmute and having to like scroll down there when I'm in department, like PHI.
How you been?
Busy.
It's true. Yeah, it's been the last couple of shifts have been really busy for me. So yeah.
Has it been RSV season for you guys too?
Seeing
I
some
haven't
of
seen
it,
that much.
but
Yeah.
everybody's seizing.
Oh my gosh. Yeah, actually we've had a bunch
Senior
of
season.
seizures recently too.
I feel like every
Yeah, I just
call
had
I
one
answer
actually.
from the EMS phone is like somebody seizing and like trying to talk EMS down from doing anything en route. Like, they're febrile? Yeah. Okay. Just okay.
I had an interesting season, kids, 2 days ago that it was unknown like seizure time, so they intubated him, and I was like, oh, they probably intubated him too quickly, and then it had an abnormal CT, and the nurse was like, I don't know what that is. It could be a bleed. I don't think it's an active bleed. But then they did an MRI, and then NR2B neuropsychosis. He was from Ecuador, ate some pork, and that's what he sees.
Oh my gosh, that's crazy.
Yeah.
So when we used to have morning report in residency, I remember there was one attending that anytime someone came in seizing, like before you could get out anything else, you're like, where's the kid from? And if it was from like Central South America, they're like, stop. Mebendazole, end of story.
Yeah. So then, yeah, I just followed up because for me, it came as an activated trauma because there was some suspicion that he fell. So then I was like, well, I have to activate. He's intubated now. And then, but then the neurosurgeon was like, I don't know what that is. Let's get an MRI. And then ID was involved. And then they got the whole history. I knew he was from Ecuador, but apparently he recently went like last year. They think that's where he probably ate it. And then it festered in his body. And then, yeah.
Oh, wow.
I didn't realize it was that common.
It's not common. It's just
It's starting to seem like it is. Yeah, Rahul and I had a good shift down at Greenwich yesterday. Rahul caught some hemotympanum in our altered intoxicated patient. Yeah, we ended up he had a
with a real temporal bone.
Yeah, and he had a subdural hematoma. We ended up having to send him to the ICU at Yale.
Yeah.
Oh, but did you do an ocular exam, Rahul? Did you do an ocular exam?
POCUS? No. I don't think he would tolerate that.
Yeah. Probably would have vomited mid-ocular exam.
Yeah. How are you doing, Henry?
I've been good.
Yeah.
Just busy at work, so we're getting a lot busier. So, but it's been fun. So.
Yeah, I hear the volumes are pretty much back fully at this point.
No, yeah, per the last email I got from our boss, there were like 129%, so we're like 30% over where we used to be seen in June before. So she like gave us the whole stats, and then May we're about like not 80% or something, but now in June we've been like over what we've seen in 2019. She's comparing 2019 pre-COVID.
Yeah.
So it's been fun.
Yeah.
So.
What are other people seeing? Are your volumes back to normal too? I think we're still just a tiny bit below our like pre-COVID.
I don't know if Matt is or Kate, but yeah, we're over. But it's been busy. So
yeah, our volumes are insane. We actually Monday, I think may have been like our record almost like ever. Like not just for July, but like ever in a single day. Like we're just ridiculous right now from where we usually are. Summers are usually like casual, like fun traumas, and then procedures and otherwise low volume.
Yeah, ours is similar. Tons of respiratory, like I'm sure you guys are all seeing, and then tons of trauma.
So the fall should be really fun then next coming. So, but it's 1:05. So thanks everyone for joining us today. So today we have Adam. So he needs no introduction, I think. So Adam, thank you for present to us, and you can take it away.
All right, let me take the screen. Alrighty. Just minimize everything here. Or maybe not. All right. So a couple of collection cases from the past few shifts. I don't know, I always thought about like trying to do like themes for these things, but you know, like I think these are kind of more random than I wanted them to be a theme. But anyway, the first one is just our usual case of some chest pain coming into the ED. So this is, you know, the average 15-year-old male. Everybody's back to school. He came in with some left-sided chest pain. So, you know, he's not doing sports yet, but he's lifting, and he was like totally maxed out the other day. And, you know, the next morning afterwards, he had some pain on the left lower side. And the resident's presenting this to me, and it's like, yeah, you know, this is like totally MSK, right? They do something exertional. They've probably been like on their couch for the past year. Like, just send me the next patient. But he's like, well, you know, he's also like a little bit nauseous, and he's like, hurts to take a really big breath, and he's really like abnormally tender to palpation over his left lower chest, really like over, you know, the kind of lower rib area. Like, have you ever seen anybody break a rib by just working out? And of course I'm like, no. But you know, I know for the rest of the group out there, you know, chest pain in pediatrics, we probably all have our spiels about how this is like 99.99% non-cardiac, nothing to worry about, mostly MSK. But I'm just, you know, curious before we move on, is there any part of that history that would lead you to do anything else for the next most appropriate test, as the PERP questions like to ask?
I don't know about given the history of it starting after lifting, maybe I wouldn't, but I usually get a chest x-ray with the pleuritic chest pain just to look for a spontaneous pneumo.
The nausea is a little weird, so that's what I don't think that I would dive into the more, like if there's pain, like belly pain or anything else. Just the nausea seemed a little weird to me.
Yeah, so you know, that was actually the part that really stuck with me also. And I'm like, well, you know, what are the chances that you could, like, I don't know, can you like forcefully give yourself a hiatal hernia if you're like valsalvating really hard? I mean, he was talking about benching, and he's like a decently muscular guy. So, you know, when he said he was maxing out on his weights, I kind of believed him. And he swore up and down, you know, non-contact football drills, like they haven't been given their equipment as of yet. So of course, you know, in this conference, the next most appropriate test is always going to be our POCUS. And so this is over the area where he was hurting. And like from the start, I'm like, holy crap, I wasn't really expecting to see anything, but he has something here, right? Like, this isn't normal looking lung. And, you know, I usually want to make sure, especially, you know, I usually try to teach my residents and the fellows, start low, make sure you can identify where the diaphragm is, so you know whether you're above or below. But in this case, you know, you kind of see like the heart beating just on the left-hand side, and, you know, whatever this is almost like right adjacent to the cardiac apex. So that surprised me quite a bit. And I said, okay, we're still going to go back into our normals, looked over the rest of like the anterior chest. He had sliding everywhere throughout. We looked at the ribs and long axis. There was no like discordance with the bone, the cartilage, like everything looked fine. So, you know, came back to this point again and looking a little bit more. And this is, you know, again, really at that cardiac apex, just above the diaphragm, and, you know, seeing this interesting looking something. I don't know if anybody else wants to take a stab at what they're seeing or what they think they're seeing. And usually when I have people around me, I'll ask them, do we think we see a pleural line? If you think no, is it a consolidation? Is there fluid? Yes, no.
Where's this, Adam? Like in the chest wall?
This is like really like apex of cardiac. So if you're coming down and doing your 4-chamber view, this is like right where you're rotating your probe to go from the short axis to the 4-chamber look. So like not quite axillary, not quite anterior, and very focal.
It's a little choppy on my screen. I think that's because of my internet connection. But I think I see some B lines, and then I'm not sure, like between the two intercostal spaces, that might just be something that's showing up weird on my computer, but I don't know. I'm seeing something between the two intercostal spaces, but that might just be muscle that I'm just making out wrong.
I'm also seeing some really, the pleural line looks really thickened and, oh, so very choppy.
Yeah, sorry, I never took a still of it, so I had it frozen
Oh,
here.
yeah.
So
Yeah,
there's
that
a
looks like
pleural line.
something, yeah, almost either like, I don't know
That's
if
the
that's,
muscle, but then there's that's
Yeah.
I mean, if that's part of the lung, then it would maybe be like some kind of consolidation or some kind of lesion in there, but maybe it's not, parenchymal in nature and some kind of like mass or something.
yeah. So I mean, to me, it definitely did not look normal in its shape. I mean, whatever this consolidation is, like it doesn't come up against the pleural line here. Like there's something else that's in between it being this hypoechoic area and then the pleural line. And then inside of it, I'm used to looking at like, branching areas and having air moving back and forth. But this almost looks like, I don't know, it's like a lumen. And there's stuff like within the lumen, and I can see through the lumen because I can see the backside of whatever this consolidation is, yet it looks like there's, bright white stuff interior to it. So
Did you use
not
color
like,
on this?
I did not throw color on it. I usually try, and I've had like such poor success on this machine that I kind of like bailed on doing the color on long ultrasound.
I feel like that's been a new goal of mine to try to, remember to use color more. But yeah, sort of the same situation.
It definitely is a goal, but I feel like I get, I don't know, I get disappointed by it more than I get thrilled by it. So, anyway, with that like chest pain and the nausea, I'm like, what's the chance that this is like a loop of bowel or a piece of the stomach that got pushed out, and that's why I'm seeing lumen, and not like the usual branching stuff that I'm used to seeing in the lungs. So someone mentioned that they got a chest X-ray with all their chest pains, and so I'm like, all right, screw it. You wanted a chest X-ray, EM resident, and an EKG? Let's get both of those. The EKG was fine. Here's your chest X-ray. And here's the lateral. So I was kind of equally as nonplussed as this. I'm like, this is very unsatisfying.
Adam, can you go back to the AP?
Sure. So this was read as normal. And so I called up our peds radiologist and I'm like, look, we did our ultrasound. I'm seeing something here. He's got way more pain than what I'm used to seeing for, regular MSK stuff, very focal. What do you think we should do next? He's like, well, you got the chest X-ray, didn't show it. You can just get, a limited CT. They look above and below the diaphragm, and see how we get there. So that is what we did. Oh. And whoever's in department, just mute yourself.
Yeah, I was trying. It was Matt. So there you
Oh, sorry.
go. So,
So here we go through it, and I don't know if you guys caught that little bit. So this little wedge right in here. So radiology said, well, it's not attached to the bowel. Looks like it's part of the left lingula. And, it could be an infiltrate, to which I said, that's would be incredible because he has no cough, no fever, and he's been doing, football practice. And then they're like, well, maybe he, hit himself in the chest. So, ask him again. And when I say that, we asked this guy like 10 different ways if he had any trauma, if he dropped a weight on him, if he was just messing around with his buddies or his brothers. No. And finally, after all of this, he's like, well, I guess we're also doing wrestling instead of like contact football drills. So he finally gave up a history of trauma, and, radiology and us could agree that this was maybe an area of pulmonary contusion. And radiology also said that there was a little bit of an effusion in there, to which I said, I like you guys, but there's no effusion there. So anyway, I mean, pulmonary contusions are probably something that we miss more than what actually exists. I mean, if I'm missing it in a case like this, because we would normally get, maybe an EKG and maybe a chest X-ray, and those things would both be normal. I'm certainly not routinely doing lung ultrasounds for just kind of run-of-the-mill chest pains, but it was a nice, interesting case for us. We're not a trauma center, so we don't see, the stuff get brought to us from EMS, although we see like, we had 3 gunshot wounds the other day because stuff just rolls up at our front door. But that was a nice little one. Now, from the ultrasound side of things, like in the past, the few times that I've seen pulmonary contusions, it has been this area of consolidation that has had like this kind of internal hyperechoic component to it. So, I had that freeze frame, kind of about in here, where you don't have your branching bronchograms, but you have, some area where it's, you have something solid and an area where it looks like kind of bright white internally. I mean, I kind of looked back at the collection of 2 other pulmonary contusions that I have clips of, and they both kind of look the same. So I don't know if anybody else who's at trauma centers who, may see this more frequently has any different experience with how the pulmonary contusions look on ultrasound.
My only experience, I've just seen like confluent B lines in contusions. I haven't seen a consolidation appearance like that. That's an interesting thing to know about.
And, early on in that ultrasound, and again, I didn't show everything for purpose of time, but there were, a lot of B lines in that area, around that little segment that just didn't look like a infectious consolidation, and certainly no history of it, but definitely had a lot of that B line look. So, all right. So that was case number 1. Let me get through this.
Adam, I wonder if that could be specific to like regions of the lung where you have like anterior, posterior, like components in the lungs, like where you're at more of like the edge of the lung, to where you could like consolidate more densely versus, a mid-lung space maybe where, because like there you're right at the heart. So you've got like lingula kind of coming across. So you're sort of already at a little wedge to begin with. Mm-hmm. Versus like B lines in other areas where it's just, there's a whole lot more lung down to be found.
Sure.
Sort of very hand wavy.
Yeah. I mean, I definitely don't know. I would defer to the trauma center's experience with that. So, all right, case number 2. So this is a little bit of chest pain, but also a little bit of back pain. So this was an 8-year-old male. Some chronic medical condition, so isn't able to come with them. And the history alternated between like cough for a month and cough for a week, and fever and poor appetite for 7 days or 3 days or just today. But the reason why they came in was really like he was also starting to have some back pain that was, bothering him a little bit more. And he was a very active guy. And when I say active guy, he is literally dancing in the ED, like moving around, way more moves than I have. No vomiting, no diarrhea, no history of COVID. His vitals are like pretty darn normal. Chest was clear, no murmurs, and really no tenderness.
Perforated appendicitis.
Ah, got me. No. But appendicitis is always on the differential. It's one of my talks. So, this is one of these other ones where you sort of like kind of throw your hands up and not sure where you're going to go with it. So it's like, all right, we'll get a chest x-ray. Yeah, I've gotten chest x-rays for less than this. Oh, sorry. Before that, I forgot about that. Do some screening labs. So, his vitals and exam were like very unenthralling. The CBC, white count of 7, maybe some elevated platelets as an inflammatory markers, differential, kind of pedestrian, CRP, same. Did an RVP, surprisingly, he wasn't paraflu 3. As much as we've seen RSV come back, we've seen paraflu 3 like totally dominate. Like, what is that organism and why is it so prevalent? But of course, we're gonna, I'm gonna skip this in. So skip the chest x-ray. We'll start with a lung ultrasound because that's always the next best thing to do. And so this was, again, over the area of his left chest that seemed to be hurting, despite his dance moves. And even as we're doing this, he like keeps on twisting around to try to look at the screen. And just by, the way the room was, it's usually easy if I can turn the screen to them so they can see it, but in this case, we couldn't. So this is a transverse view, which is why it looks a little bit oblique. We don't really see the ribs clearly. And you got some normal looking lung, but then you have this area in the middle where it looks, again, consolidated, but not the usual consolidation. Oops, sorry, I'm gonna freeze it. So, you definitely have like a clear difference between normal lung and where you have the area of consolidation. Again, not seeing the normal, branching air within that pulmonary section, certainly not seeing air moving back and forth within there. Oddly enough, I have this weird like white line that's kind of like smack dab in the middle of this thing. And used to seeing normal looking lung in and around your disease section, but usually you're kind of surrounded by B lines, and this is just like a nice straight line. And it has, no difference in shadowing posterior to it. And, he didn't like ingest anything, he didn't choke anything, no chicken bones, no fish bones. I know this one's a little bit darker than that last one, but this is kind of like another plane of view. Maybe the last one was more oblique and this one is more transverse, but really that like, so this is that area of consolidation again, but like, I don't know, that white line in the middle of it was bothering me. So here was that kid's chest x-ray with the very unimpressive vital signs and the very unimpressive white count. But he did have a nicely impressive consolidation on that left-hand side, which, I don't think anything was trying to be made up here, but it looks like there's a circle in the center of it. much easier to see on the lateral. And so that bought him his chest CT. And so that was what we were looking at, was his nice little consolidation, but with an air fluid level in there and his pulmonary abscess. So this kid is, when did he come in, 2 or 3 days ago? I saw him the other night at the end of one of my shifts. He's still dancing. He's like totally afebrile. He's probably like the healthiest kid in the hospital. But I think they're still waiting on TB testing on him, and still have him on IV antibiotics for the time being. His white count, like as impressive as that was on the first time around, when they repeated it like less than 24 hours later, went from a quasi left shift to like no left shift. It went from like the 17 to 50, 40, 10 on the differential. And not quite sure
Can you
why.
go back to the chest X-ray real quick.
Sure.
Also, there's an air fluid level in there. I see it now. Okay.
Yeah, I can't see my own mouse on this screen, but yeah, and they talked to IR about doing drainage of it, but I think as good as the kid looked, they're like, well, just leave him alone and let's see how he does with the medical management.
Why did you admit him?
I think given the complicated social situation, and the question of how long his symptoms were going on for, and the ultimate etiology of what it was.
I mean, we had a similar case and I had this huge fight with the ID department. I don't know why somebody called them. I said, this is, can be treated as outpatient. Most of these kids do fine unless they have immunocompromised or they have aspiration risk factor. But it's a healthy kid. You can send them home on some kind of anti-staph medicine and they usually do okay. But yeah, ID insisted on admitting somebody like that. And I said, no, I sent the kid home. They never came back. Presumably they're fine, Adam. But I think the challenge is that when we consult subspecialties, they have a different cohort. And certainly, if you call ID, they're going to want to, put a PPD and, do HIV tests and all that stuff. But the kid looks okay. Yeah. Anyway.
Yeah, no, those are really difficult things. And I'm sure you kind of have the same social situations that we all do sometimes where like, outpatient management on one child would work, but maybe on another one might be a little bit hairier should they have to come back in.
What did you choose to treat him with antibiotic wise?
The initial recommendation was Unison.
Okay.
And I think they've stuck with that for now. All right, case number 3. So this was a 5-month-old male who was actually a twin, came in with vomiting, not tolerating POs for the past 2 weeks, maybe a little bit more. Hadn't been to the PMDs since the 2-month visit. They had missed their 4-month visit. Vomiting was non-bilious, non-bloody. There was no bloody diarrhea. There was no any diarrhea. Child was still somehow making some wet diapers despite throwing up literally every single feeding, as per the mom. The vitals looked stable, but when you looked at this kid, the abdomen looked kind of pruny, and I was thinking like, wow, it's been a long time since I've seen a prune belly syndrome. And then you look at the rest of the kid and like everything was pruny, like skin was falling off this dude. And the mom was like, yeah, we got a weight on here, and he's actually lost 2 pounds from the last time that he had a weight. So not flattening out, but losing, I forget what percent that was. He went from 12 pounds to 10 pounds. And all from the vomiting. And there was, some history that, might have been some like milk protein allergy. Mom was breastfeeding. She took all the milk related products out of her own diet, but had this kid nonstop vomiting. So differential and most appropriate step, next step.
So it almost sounds like a pylorus in a 5-month-old. So for me, if it's complete oral intolerance, I'm mostly going to key in on some sort of mechanical obstruction, potentially higher up in the GI tract, if this kid's really looking so dehydrated and the weight is down.
Yeah, and that was like the initial thing from the residents, like, oh, I got this 5-month-old that I think has pyloric stenosis. And I'm like,
Tool, right? Tool.
Yeah.
Unless.
But of course, for this thing, the next most appropriate test is going to be our ultrasound. I'm going to skip the pyloric part just because I'm going to tell you that that part was all normal. And actually had a really, maybe I should have put it on because it had a really good wave of peristalsis that was coming like right through the pylorus. And like that was the teaching point for the resident. Like once you see this, you don't have to worry about stenosis anymore because you don't have stenosis. But we actually took it to the next best thing for obstruction in these toddlers, which was, a rule out ileocolic intussusception, which would be really weird for a kid to A, be non-bilious, and B, have a stomach that like, was totally cachectic appearing and have something in there. So I wasn't really expecting much. This is the scan coming on the right side of the belly. I do it opposite of the upside down U. I'll start from the right upper quadrant and then come down to the right lower quadrant, looking at ascending colon. And if we're not seeing target stuff by this point, then we don't really have an ileocolic intussusception. A lot of fluid in the bowel. There was fluid in the bladder. So the belly really didn't look like much. I usually do a sagittal view of the area. And on our sag, keep going. Whoop. So a little bit of a surprise.
How big did it measure?
How big would you like it to measure?
I'm laughing.
No, so this actually, it's a big question mark, and it actually came to a point of contention between us and radiology on a case a month ago. And, kind of as busy as we have been over the past month or two, we've seen a ton of paraflu 3, and whatever's running through Newark is causing everybody to have vomiting and diarrhea. And so, we've looked at lots of bellies, and this may be like the 3rd or 4th small bowel intussusception that we've just kind of like bumped into incidentally, like of my own. And so, I really don't do much with them once I see them. But we did have a case in our department when I wasn't around where one was seen and was sent to radiology relatively quickly, where it was seen again. And radiology, wanted to err on the side of caution and try to like reduce it. And so the question came up later in review because, after review, it was kind of clear that it was also small bowel, like everything else. Like, what is that size that would tell you that this is, definitely small bowel versus ileocolic? And so, honestly, I do throw that out to everybody else. Like, I think this thing at its most measured 1.5. And more views was closer to the 1 than the 1.5. So, and, when you look at it here, and maybe I'll try to pause it where, if you're looking for things up and in and around the hepatic flexure, Like, here's your liver and here's your target.
Did it reduce for you, Adam, when you were scanning?
Did it? Oh, did it
help
reduce
while you were scanning there?
Not while I was scanning, but it did have active peristalsis within it while I was scanning. So, you know, this was small bowel. You know, we see it here, and it's in all of its glory. It's small. When you rotate the other way and try to get a length, it was, you know, no greater than probably like 2 centimeters. So you could scan through it. You can see where the normal bowel, small bowel was. You can scan back the other end, and you can see, you know, the rest of the normal small bowel. And you can track, you know, the entire large bowel. And because of the weight loss and the other things that were going on, this kid ended up getting admitted as a failure to thrive. His lights weren't actually all that bad, and he's still inpatient at this point. But they did repeat the ultrasound, you know, because we had to tell them that it was there. And by the time he went to radiology, even telling them like exactly where we found it, it wasn't there anymore, which is, you know, usually what happens. But I do find that, like, as we do more of these, you know, this is always the concern, that the more that you do, the more that you're going to bump into the small bowel intussusception. And, you know, on all these cases that come in, you know, when I'm pimping the med students and we start talking about what are the causes of vomiting that are going to make you worry and you want to do something about, you know, eventually there's some line that says, well, the most common cause of obstruction is going to be intussusception. And, you know, it's more common, or ileocolic intussusception, and more common than small bowel. And I don't know, I feel like, and I don't think that our recent P2 study bore it out, but I feel like my own experience says differently, that I feel like I'll find like 4 to 1, at least 3 to 1, 2 to 1. But this spring, especially 4 to 1, small bowel intussusceptions than I will ileocolics. And so I, again, throw it out to the rest of the group for what your guys' own experiences are.
So
and what you guys do when you have these on bedside, whether you know, bother bringing in radiology or not.
So I've over the last year, I've had I want to say 4 to 5 or so small bowel intussusceptions. And if the child feels better and they calm down, if they're in a lot of pain, then I'll repeat it. But if the child is otherwise asymptomatic and they were, you know, this was kind of more of an incidental finding, then I will just, you know, feed them and send them home. But I wanted to share, I had a really not interesting case, but interesting call a few days ago. I got a call from an outside hospital. They wanted to transfer a 10-year-old boy with an intussusception. The EM provider, she's like, I have this 10-year-old boy with an intussusception. And I was like, all right, so how big was it? And she says 11 millimeters. And I was like, that's a small bowel intussusception. That's nothing. You know, we're happy to see the patient, but let them know that this is nothing serious. And, you know, don't, you know, because she thought like this was like a major find. And I wanted to let her know that it was just nothing. And I think that, you know, adults probably don't, they seem to not understand it.
Yeah, Stephanie, I mean, you know, our catchment area, and we've taken a couple of calls for the same thing, for small bowel intussusceptions, where, you know, once they hear the word intussusception from radiology, like it's all done.
Yeah, the only time I've seen a small bowel cause morbidity was an HSP kid. It was about an 8-year-old, and it was, interestingly, it was jejunal. It wasn't ileal, and I think it was persistently there on sort of. It was a patient admitted for severe abdominal pain, HSP care, persistent on serial ultrasounds, and then ended up going to the operating room and did need some, I think, bowel resection. So it's kind of a humbling one, because it was small bowel, a little atypical, but you know, these HSP kids, a little bit different inflammatory process going on. So I pause when it's an HSP or something else that could potentially cause, I guess, more protracted small bowel. But in general, I agree with everybody. You know, we're small bowel, especially kids that are having enteritis symptoms and pretty mild exam and well hydrated. Just sort of have a conversation about the bad intussusception and the not so bad intussusception with caregivers and anticipatory guidance. And I really don't see the majority of those come back with any issues.
So last week I had a case where it was a 6-month-old that I was seeing in our satellite ED, like coming in for crying, just crying, like, and she was really crying a lot. And I was like, wow, you're really crying. And she had this incidental fall off the bed like 3 days ago or something. And then it was like the whole, like, is this NAT, blah, blah stuff. But I didn't get the NAT vibe really. And she had been fine for 3 days. So I was like, well, do I scan her head, not scan her head, that kind of thing. But then I was like, I'm gonna look in our belly. You know, we did Tylenol, we did Motrin, she went to sleep. I was like, all right. And then she got back to crying. And I was like, well, all right. So I looked and there were 3 ileal, and the biggest I measured was 1.9. And this was on the left side. And I was like, wow, that's a little generous for ileal. I mean, it can't be ileocolic, it's all the way on the left side. But then she had a 3 and then all the crying. So I was like, fine. So I sent her to the main. And then by the time she got there, she had none of those things. So I was like, well, there you go. And I took a picture and, like, you know, texted it to my colleague at Maine. I'm like, look, I'm not sending goofy stuff. This is real targets. Look, I'm sending you actual business, because, you know, they were exploding over there. And they're like, why are you sending me another child? So I was like, no, really. But she was fine. But I was like 1.9 on the left. And I was like, well, if I measure a little bit more, I can make it 2, you know?
Yeah. So, I mean,
Adam,
that measurement I've seen anywhere between like the 2 and change and around the 1.5, but it really is like a very gray zone. And I think even within our study, there was somebody that was a positive ileocolic who might have been, again, right at that like 2 mark.
Adam, I would agree with you. I feel like I see way more small bowel only, especially now that I'm doing like more like teaching scans with residents and fellows, and just like going and doing like teaching like an API-INTUS scan on like a soft gastro who actually doesn't need any real imaging. And it's just like, there you go. Like there's one, there it goes, there it comes, there it goes. Although I also find location for me is sometimes still weird. My last current jelly stool kid was ileocolic in the left mid, and it was all the way down to like his sigmoid. He'd like doubled the whole thing over. And like radiology and surgery were like quite concerned. He managed to reduce just fine. I also had a weird one last week that was the spitting image of intus, like toddler, episodic pain, vomiting, and looked, and I usually start mine right lower and could like see what looked like a normal ileocolic junction pretty much from the get-go, and tracked colon up, and I was like, okay, so I don't think we're ileocolic. But then I sort of got buried right upper quadrant, like right next to the gallbladder, and there was something that was wrong. And the kid was so fussy that it was hard to like rotate and get orthogonal views. And it was the size that I would associate to like small bowel. And then when I looked later, and this was sort of after she got admitted and I had radiology do it and they didn't see anything, she ended up getting scoped and had really bad esophagitis and duodenitis. And looking back at my images, I'm like, I think maybe that's just really pissed off duodenum, because I could actually make out more of like inflamed bowel layers, and I wasn't really seeing like true like target. So I don't know, it was weird. That was one I'm going to try to throw in the next time I do this to get the quorum opinion on.
Yeah. I mean, I think that's something that's in the lit, that when you have like I mean, I've never heard of the duodenitis, but certainly like the colitis, that when the layers get like inflamed and thickened and hyperechoic and kind of against each other, that's one of like the fake outs for an ileocolic. But duodenitis, definitely throw that one on your list.
And, you know, I'm just listening to everybody reminded of a case I had. This was, gosh, almost, you know, I've been here 10 years now. This was pretty early on. And I was doing a practice scan with one of our fellows, and we were scanning a 7-year-old girl who had been admitted for the weekend for abdominal pain. I think she'd been to the GI service. She had had some chronic abdominal pain. And we were just doing like a practice fast exam. They'd already talked to GI. She was already being readmitted. And so my fellow, you know, looks in the right upper quadrant, it looks fine, and then starts to look for the bladder, but was a little bit high. And he says, is that the bladder? And he's like right on top of the small bowel intussusception. And I was like, no, that's not the bladder. It caused a little problem with my colleague, who was very upset that she missed it. And the child, they actually surgery saw her and actually took her to the OR because it had, I guess, been there for so long, and she did fine. But again, incidentally, we weren't even supposed to be looking at her. Nobody even thought to ultrasound her belly.
Wait, they took her to the OR for a small bowel?
Yeah, yeah, because I guess they were assuming that it had been there the whole. She had been hospitalized all weekend with abdominal pain, and she had been, I think, admitted Friday night, and she was discharged on Sunday, and now this was Monday morning. I'd have to go back and look at the chart. This was, like I said, many years ago, and so we were just doing a practice scan and happened upon it.
Things we'll bump into. All right, moving on. Case 4, more belly pain. So this was a 12-year-old girl. I think I have it wrong. I think she was actually younger than that. She was like 9 or 10. So she came in with dull belly pain. It woke her up at 1 a.m. that morning, diffuse, no vomiting, no diarrhea, up and down, no trauma, just a regular kid. Vitals stable, belly was soft, but some moderate tenderness. And I'll add, there's as much gastro as there's been around Newark, there was no gastro in her home that she knew of, and none of her friends. I think it was a midweek, so nothing that happened on the weekend. It wasn't around July 4th, so nothing that looked like enteritis. Just gonna skip to the good stuff. So I think I was we have a new ultrasound fellow and just doing fast. So like, we'll start with that, then we'll get to the area of interest. And so our right upper quadrant view, and oh crap. So really nothing that went like into Morrison's, but definitely fluid that you can see at that lower pole of the kidney and the tip of the liver. Came over to the splenic side. And maybe some fluid around here. Couldn't be sure, certainly wasn't as impressive as the right upper quadrant. And then we're going to get down to the pelvis, kind of starting on the right side. So here you have your psoas muscle, iliac artery and vein. Lots of fluid. It's like, well, maybe she's got like a ruptured ovarian cyst, but so there's her right ovary. Looks fine. Doesn't seem to, be very, she's got cysts, but like no large cysts. And, when we're looking at the fluid all around here, this is very anechoic fluid. Doesn't look like there's any other stuff in it. It's not complex. Coming over to her left side. So bowel, her left ovary is sitting down kind of underneath the mouse, and come back again. Her psoas and iliacs are over here. And so I don't know, I mean, she had, I guess, more stuff on that left side, but nothing that looked very specific. The uterus looked fine. The bladder was fine. And again, up and down, any trauma? No trauma, no bruising on the belly, no bruising on the back. So, the consults were called, the labs were done. She hadn't dropped her hemoglobin all that much, and the consensus was they were going to repeat the ultrasound. So radiology did a repeat. They kind of saw the same things that we did, but on that left side, in amongst the stuff that they saw, they threw the color on, and they actually had some like internal signal in an area where you wouldn't really expect it. So they thought that maybe there was like a soft tissue mass. The rest of it looked like it could have just been some clotted blood, but there was definitely an area with like very distinct vascular signal. in that left adnexa. So she ended up getting an MRI. And so there's the ovary, and coming back through, here's some abnormal signal that's wrapping around and then ties back up with her left iliac vein, which was eventually read as bleeding from a pseudoaneurysm from a branch of the left iliac with bleeding. Etiology undetermined. And again, swore up and down that there was no trauma, no nothing. And, you know, her history was pretty convincing that like pain just woke her up like that night, regular kid the day before. And so unfortunately, I don't have a great answer with this one because we don't have pediatric vascular surgery, and then the trauma center is up the street. And our pediatric surgeons, if they hear the word trauma, are immediately send them away. So she got sent away. I need to follow up with you know, whatever her end diagnosis was. But just a interesting case of a belly fluid full of blood. And you know, we see these every so often and end up just as kind of like a ruptured ovarian cyst, and you know, we don't really go like the MRI route. And we've seen kids who've, you know, dropped their hemoglobin and they just transfuse, and will sit on the floor and watch with, you know, OB kind of like sitting by their side and never get an MRI. So it was, I guess, very fortunate that radiology did what radiology is supposed to do and found something with that extravascular signal internal to it. All right, got maybe time for one more case. And I think the last one actually is a very quick one, so this is probably the better one to go through. So this is another adolescent male, comes in with very acute right lower quadrant pain, very similar to this last girl, who woke him up in the middle of his sleep. A little bit nauseous, hurts to walk, but not vomiting, still tolerating liquids. His vitals were all normal. And on exam, he had some, you know, decent right sided and right flank pain. So I'm always thinking appendicitis if somebody says the magic word of right lower quadrant pain. And so this is just an initial look down at that right lower quadrant. And if anybody sees anything of interest, you can shout it out. And for just landmarks, skinny dude, subvertebral bodies, psoas muscle, iliac artery, iliac vein.
Matt said rupture iliac pseudoaneurysm.
That was the last case.
Recency bias.
So we got this dude sitting up here, which, you know, looks like it's a tubular-esque structure that's in the right lower quadrant and seems to be coming from the right area and doing the right sort of thing of flopping over the psoas muscle and the iliac vessels. Doesn't look big, doesn't look like it's inflammatory change, but doesn't quite look like the appendix. So I'm going to throw a little color on there and just see, you know, is there any hyperemia of the walls, or is there any internal flow? And there was really no internal flow at all, and the walls weren't lighting up. So this guy had, you know, right lower quadrant pain, and as we're doing the scan and kind of moving up, trying to trace this thing, you know, he still had pain that was coming up to his flank. So get up to his flank. Usually have the kids, when they can, to roll over. So my renal views are kind of coming more from like the posterior, from the back. And got a nice little something that looks a little bit bright over here. Roll it, rotate the probe into a longer view. And so he's got something that's sitting in there that has, there's a rib that's in the way, so can't really tell if we have shadowing or not. But maybe this is the one time where throwing on some color actually does a little bit of good. So you can see the rest of the renal parenchyma lighting up, and then this thing in the center is giving you some of that high velocity flow, or what looks like it. And so a nice little twinkle artifact from a stone that's in his right kidney. And that thing that we saw was probably a little right hydroureter that was coming down to his bladder. Oops, sorry. So now the issue with him was when we tried to get to his bladder, he had already peed, and those bladder views are not very satisfying after someone's peed. Couldn't see any twinkle artifact, but he was peeing some blood, so some right renal colic. And then the question is, well, what do you do with this guy? Do we need to get a CAT scan on him? Like, we can see a stone in the renal parenchyma, and he didn't really have hydro. The rest of the kidney looked fine. He's got some hydroureter, which is interesting, but not really part of my algorithm. It's really like hydronephrosis, yes, no, and if no, then just sort of like manage him conservatively, which is really all that we did. He got a lot of fluids, he got a lot of POs, he felt better in a couple of hours. And we saw this guy a couple of months ago, and he hasn't returned as of yet. So I feel pretty good about him. And I do have just one more case, which I know we only have 3 minutes, but there's really only like 3 slides, and they're very simple. But this is another one of these benefits, these conferences. So I think Antonio presented this, I don't know if it's been like a year at this point, of doing ultrasounds on these little kids who've got the unwitnessed injuries, and then they're not moving their arms, and you're worried about whether it's a nursemaid's or not. So I had one of these guys. I always look at the Lecranon fossa just to make sure there's not an effusion there. It's really pushed me to x-raying or not x-raying when the history is kind of equivocal and you can't really examine the kid. And this one, cried if you looked at her funny. This is long axis view of that proximal radius. And here's that little hook area that we're supposed to be looking out for. And for a long time, I had to like really convince myself, like, what's a normal hook? What's an abnormal hook? I don't think I've done any measurements, but usually what I'll do is, get a nice comparison view between one side or another. So, here's the left side, and there's really not much of a hook. And there's the right side, and you can see that hook kind of like coming about halfway down the bone. But it's, hooking more towards the right-hand side than certainly the left one. And, had a very nice satisfying crank on the arm. So we have a before view and we have our after view, and the after view looks a lot like the left-hand side. So, I don't know how many times it's kind of saved me from avoiding doing an X-ray, but it's nice to learn new things. And so, it's a fun conference.
I'm so happy for you, because I remember last time you were like, me, I don't know. So this is great.
Yeah,
it's like, for me, it's like when I find the appendix, like you feel so comfortable doing that, I'm like, oh my God, like it's that opposite feeling. So I'm so happy for you, because it feels great when you're like, aha, I now know what people are talking about.
And I still don't want to like try to get a measurement and have something say like, well, if it's 3 millimeters, it's this, and if it's 2.5, it's that. I still kind of like this, sort of gestalt look at it. But yeah, always fun to learn new things from this group. So thank you guys.
I'm gonna double down on that, Adam. Rosemary, thanks to you, I looked at that paper and I had a similar presentation, same thing. I was like, well, let me look at it, and then same thing. I actually had a before and after, and the resident was pretty excited because he was like, oh, this is something new. I was like, actually, it hasn't been new. I just learned it. So it's a shout out to you, Rosemary, as well.
No, a shout out to you for this conference, right? Because you're helping us all. So yay. Yay, team, everybody.
And that's all I got for you guys. 2 o'clock. Time to head to the
Thank you.
pool.
Yeah, thanks, Adam. Great cases. Thank you.
Thanks so much.
That was great. Thanks, Adam.
See you guys.